Hello, welcome to the lecture on the renal system and urinary tract anatomy and physiology, neuro and hormonal control. My name is Wendy Wallen and I am a PA in San Francisco, currently working in transplant surgery, and I'm happy to give this lecture as I do work mostly in kidney transplant and have a distinct interest in the renal system. The first few slides are our objectives, so I'll pick up with the audio on the fourth slide. Thank you. At this point, you are all probably very familiar with what the kidneys do and their basic function, but I just wanted to do a quick review. The kidneys are located in the retroperitoneal area, located between the lower thoracic and upper lumbar vertebrae. Each kidney is approximately 11 centimeters long, 2.5 centimeters thick, and 5 centimeters wide. So sort of the size of your hand if you were to make a fist with your hand. Functionally, kidneys play a key role in many functions of the body, and a mnemonic that can help you remember these functions is a wet bed. So they are involved in acid, base, water, and electrolyte balance and regulation, toxin removal, whether that's drugs or metabolites, blood pressure control, and making erythropoietin and vitamin D metabolism. We're going to start out looking at the entire kidney, and then as we go through the lecture, we'll be getting down into the smaller and smaller structures. I first want you to notice these pyramids, or these triangular shaped structures within the kidney. In this picture, there are 9 pyramids, and they look sort of like candy corn to me, with a sort of lighter section and a darker section. The nephrons, which are the functional unit of the kidney, are located in these pyramids. And essentially urine is made in the nephrons in the outer light part of the pyramid called the cortex, as well as in the deeper part of that pyramid called the medulla. And there are over 1 million nephrons in each kidney. Urine then exits from the nephron and flows out of the pyramid into the major calyx, the minor calyx joining into the major calyx, and then the renal pelvis, and eliminated via the ureter. So take a moment to look at this picture to see where those different structures lie. Now, as we look more closely at one of these pyramids, you can see a couple nephrons inside. And what I want to point out is that some of the nephrons are lying within the cortex, which are the superficial lighter brown area, and some of the nephron is located in the medulla, which is the darker brown area. And this is important as it enables the kidney to adjust how dilute or concentrated the urine will be. And we'll get into more of those details coming up. Each nephron can be divided into 5 main sections with different abilities for secretion and reabsorption. I'm going to go through all 5 of these structures in more detail, but first wanted you to see how they connect to each other. So going from left to right in this picture, you'll first see the glomerulus and Bowman's capsule, then the proximal convoluted tubule, then the loop of Henle made up of the ascending and descending limbs, the distal convoluted tubule, and then the collecting duct. I also wanted you to note that there is a rich blood supply around the nephron, and this allows for communication through secretion and excretion of water and electrolytes between the urine that's being produced and the bloodstream. I wanted to go through the basic blood flow that's happening here, although I don't think it's important that you remember all of these details. I just would like you to get a big picture of the blood supply. Blood enters from the aorta to the renal artery, and then to the interlobar artery, and then the afferent arteriole. After the blood gets filtered in the glomerulus, it exits the efferent arteriole, which becomes the vasa recta, a series of vessels surrounding the nephron. Vessels around the vasa recta are in close contact with the rest of the nephron where water, ions, and electrolytes are exchanged. Blood then drains into the interlobar vein and eventually the renal vein and inferior vena cava. We're going to talk much more about the vasa recta in upcoming slides. The rate of urine production is the net result of three processes: glomerular filtration, secretion, and reabsorption. And we're going to look at each one of those terms in a little more detail. Filtration is performed in the glomerulus, and it's a non-selective process depending on hydrostatic pressure, which in the body is essentially the blood pressure. Tubular reabsorption of water and other substances occurs from the renal tubule to the blood as a way of moving usable materials back into the blood, whereas tubular secretion of substances is moving fluid and electrolytes from the blood into the renal tubules. This reabsorption and secretion are done via active transport, passive transport, and osmotic gradients. So the key thing to remember is reabsorption means that water and electrolytes are moving from the urine to the blood, and secretion means that water and electrolytes are moving from the blood to the urine. The ability of the kidneys to move things back and forth this way gives it a lot of power to do the important fine-tuning that's needed in the body. Okay, so now we're going to really jump into the details of each of those 5 sections of the nephron, starting with the glomerulus. Now remember, the glomerulus plays a big function in filtering fluid and electrolytes from the blood and deciding what is going to go into the urine. Blood flows from the afferent arteriole to a small capillary bed where the first step of filtration occurs. 80% of the blood volume entering the afferent arteriole exits the efferent arteriole, so approximately 20% of the blood volume is filtered. Of that filtration, on average, only 1% or less of the volume is ultimately excreted as urine. After filtration in the glomerulus, the blood then leaves via the efferent arteriole into peritubular capillaries arranged around the renal tubules. And then any filtered urine moves on to the proximal tubule, which is going to be the next structure we'll talk about. So how does the filtering occur in the glomerulus? The capillary cells of the glomerulus are surrounded by a few different cells called mesangial cells and podocytes. In the structure labeled A, the mesangial cells are purple and they're crowded toward the middle, and the podocytes are light blue and they look like small mountains going around the perimeter of the stalk of the glomerulus. You'll also see 4 different capillaries, which look like 4 kind of oval shapes that are looking at the capillaries from a cross-sectional view. If you look at structure B, labeled B, you can see those layers in a little more detail. And these are 3 different layers that the blood is filtering water and electrolytes through. The layers are, the first one is the capillary endothelium layer, then the glomerular basement membrane, and then an outer layer containing the podocytes, which contain other structures called foot processes. In structure B, you can also see in the capillary lumen, they have a few different cells floating there, maybe some red blood cells and some white blood cells that are obviously too big to fit through those 3 layers. So you can appreciate how when you see red blood cells or white blood cells in the urine, that would be abnormal and give you a clue that there's some issue with the filtering process. So as I mentioned with the previous slide, these endothelial capillary pores prevent large cells such as red blood cells, platelets, and white blood cells from passing through the nephron. And so a urine sample that has these different findings do suggest some sort of pathology, because normally they would not be spilling into the urine. Also wanted to talk a little more about the filtration of blood and how it is dictated by your blood pressure going into the glomerulus. The nephron can increase filtration by increasing blood pressure or increasing resistance or constriction of the efferent, which is the outgoing arteriole. So essentially the kidney is slowing down the outlet of the blood, so the blood spends more time in the Bowman's capsule and more filtration can occur. If the nephron wants to decrease filtration, it can increase resistance or constrict the afferent incoming arteriole, so less blood is let into the glomerulus and less filtration will occur. How does the glomerulus know when to increase or decrease filtration? Well, there's specifically an area called the juxtamedullary complex that regulates the blood pressure. The juxtamedullary complex or apparatus is a specialized structure formed by the macula densa cells of the distal convoluted tubule, granule cells, mesangium, extraglomerular cells, and the glomerular afferent arteriole. Now, we haven't talked about the distal convoluted tubule yet, and we will get to that in just a little bit. It's one of the 5 main structures of the glomerulus. But essentially, the distal convoluted tubule is in communication with this part of the glomerulus, kind of giving it feedback as to whether the glomerulus needs to increase or decrease filtration. I think this picture helps to understand the orientation of how the proximal convoluted tubule sits next to the glomerulus and how they are communicating to each other. Look at the blue arrow and you can see how the distal convoluted tubule kind of loops back up and sits right next to that Bowman's capsule. Let's get into more detail about how the juxtaglomerular complex regulates blood pressure. As you remember, it's located near the vascular pole of the glomerulus, and it can regulate blood pressure and filtration in 2 ways. First, the macula dense cells of the distal convoluted tubule sense the sodium concentration, and if that level is decreased, which indicates dilute urine, the macula densa cells trigger contraction of the afferent arteriole. This reduces blood flow and hence decreases glomerular filtration, giving the final effect of keeping fluid in the bloodstream rather than being filtered out into the urine. The juxtaglomerular cells also have the ability to secrete renin when the blood pressure in the arteriole falls, which is sensed by baroreceptors. And by secreting the renin, this increases the blood pressure via the renin-angiotensin-aldosterone system. This is another way that the kidney conserves urine excretion and keeps fluid in the bloodstream. So you can see how this renal regulation of the GFR gives the kidney the ability to adjust the GFR under systemic changes. Let's look a little deeper into what the glomerular filtration rate is that we use as clinicians, and this is a value that we can get from a basic metabolic panel. The glomerular filtration rate is the volume of fluid that filters into the Bowman's capsule per unit of time. This is milliliters per minute. The heart pumps approximately 500 milliliters per minute of blood, 20% of which is filtered by the kidney. On average, women filter 150 milliliters per minute and men 125 milliliters per minute, which is about 180 liters a day. The exact filtration can be measured by using an exogenous filtration marker such as inulin, but this is not routinely done and doesn't need to be because we have figured out a way to make this calculation via the eGFR or estimated GFR. And this is a calculation based on a patient's creatinine level, as well as other variables such as age, race, and gender. There are a number of different formulas used for estimating GFR. You do not need to memorize these, but just know that they're available. You can actually find really helpful apps that will calculate this for you, or if you're in a hospital, the pharmacist can also help you with these calculations. But you can get an idea of how the creatinine, race, age, and weight factor into the formulas. The urine that's been filtered from the glomerulus now passes on to the second structure in the nephron called the proximal convoluted tubule. As you remember, the nephron traverses both the cortex but the proximal convoluted tubule specifically lies in the cortex layer. The majority of water and solutes are reabsorbed at this stage from the proximal convoluted tubule through the interstitium back to the bloodstream. The interstitium is a fluid-filled space existing between the nephron structures and the blood vessels, which in this area is called the vasa recta. The interstitium acts as a passive conduit system for the flux of fluid and solutes to travel across. Both secretion and reabsorption occurs across the wall of the proximal convoluted tubule such that solutes and water can travel back and forth between the urine in the tubule and the bloodstream. Remember that secretion is when things travel from the bloodstream into the tubule where the urine is, and reabsorption is when things travel from the urine in the tubule back to the bloodstream. You'll notice from the slide that there are a lot of things that are secreted at this area from the bloodstream to the tubules, and I wouldn't say you need to memorize these, but just you can see that there is a vast number of substances, water, chloride, potassium, different drugs, proteins, acids. But what I really do want you to notice is that this is where there is a large reabsorption, specifically of sodium, water, and bicarbonate. Some of this reabsorption and secretion occurs through passive movement. Some of it occurs through pumps, such as the sodium-potassium ATPase pump. But the important thing to remember is 65%, or a large amount, you don't specifically need to remember 65%, but a large amount of sodium gets reabsorbed at this point. Remember that water follows sodium, so an equal amount of sodium gets reabsorbed here from the tubules back to the bloodstream, and 90% of the bicarb. So for example, in a person who's got renal tubular acidosis, a condition where the renal tubules in the kidneys have been damaged, you would see a acidosis in the bloodstream because this part of the kidney is not working correctly and it's not reabsorbing the bicarbonate back into the bloodstream. I also have a picture on this slide of the proximal convoluted tubule wall and how blood is lying on one side, urine is lying on the other side, and there's a passage of fluid and solutes between the two. The third structure in the nephron connecting to the proximal convoluted tubule is the loop of Henle. The ability of the kidneys to produce either dilute or concentrated urine depends on the gradient in osmolarity between the renal cortex and the medulla that is created by the loop of Henle, and this is called a countercurrent multiplier. The countercurrent multiplier is the two limbs, as you see in the loop, that are in close proximity and are flowing in opposite directions. You will be able to see in the next few slides how that facilitates exchange of solutes, and fluids. Within the loop of Henle, there are two different kinds of nephrons, juxtamedullary and cortical. The juxtamedullary nephrons have the long loop of Henle and dip into the medulla, which is surrounded, this long loop is surrounded by the vasa recta. They have a much bigger role in making concentrated versus dilute urine. In contrast, the cortical nephrons have a shorter loop of Henle and do not go deep into the medulla. And so they're not as much involved in water regulation. They're instead more involved in excretory and regulatory functions. So once again, we see the cortical nephrons and the juxtamedullary nephrons. The cortical nephrons are the ones with the shorter loops of Henle. So you're going to see them in the cortex, or the outer layer of the pyramid. And in this picture, that cortex layer is the lighter brown. And then the juxtamedullary nephrons are the ones with the longer loops of Henle that are located in the inner layer, or that darker brown layer called the medulla. And this is pretty easy to keep straight because the names correlate with where they are laying. So the cortical nephrons are mostly in the cortex, and the juxtamedullary nephrons are mostly in the medulla. And we'll see in the next slide how the juxtamedullary nephrons with the longer loops of Henle are able to more adequately create concentrated urine. Here's a closer look at those long loops of Henle that function via a countercurrent mechanism. The countercurrent mechanism moves water and solutes back and forth. As you move deeper into the medulla, the osmolarity of both the blood and the urine gets higher, more concentrated, as you can see in this schematic on the slide. As you look specifically at the descending loop of Henle, you'll note that this is where there is primarily reabsorption of water. This reabsorption is happening from the urine back into the bloodstream by osmosis because the interstitial fluid is very hypertonic. This is the way the body is able to make more concentrated urine. Now look over at the ascending limb, and you'll notice that this is a primary site for the reabsorption, meaning it's going from the urine to the blood, reabsorption of sodium, potassium, and chloride. And this is done via active transport mechanisms in the wall of the renal tubule. And more specifically, the sodium reabsorption is the active transport, and the chloride and the potassium are by diffusion. You can also get a better look at the vasa recta and appreciate how they are a series of multiple small blood vessels that make hairpin turns around and alongside the loop of Henle. This helps to slow the return of blood and aids in creating this osmotic gradient. So the big picture on this slide is that primarily water gets pulled out of the urine as needed in the descending limb, and sodium, potassium, and chloride get pulled out of the tubule in the ascending limb. The fourth structure in the nephron is largely for fine-tuning. This is the distal convoluted tubule. Urine has just passed through the loop of Henle and is now more hypotonic. The thick ascending limb of the distal convoluted tubule is involved in sodium, potassium, calcium chloride bicarbonate, and hydrogen exchange. You don't necessarily need to remember all that, but it is under the tight homeostatic control of hormones, specifically the adrenal steroid hormones such as aldosterone. And that is more of an interesting point. We'll get into more detail about how aldosterone affects the distal convoluted tubule a little bit later in the slides. But in general, only minor modifications of the tubular fluid are occurring here, and that's because there are many tight junctions and this tube is somewhat impermeable to water and sodium. But the small modifications that you would see would be reabsorption of sodium. This accounts for only about 5% of the sodium reabsorption that happens, water and calcium, and secretion of a variable amount of potassium and hydrogen. And finally, we're at the fifth and last structure of the nephron, the collecting duct. And the collecting duct is a series of tubes that descend through the cortex and medulla, fusing together toward the papillary tip and then papillary ducts and essentially into the calyces. It's sort of like a big gutter on the side of your house that is collecting rain and facilitating its exit toward one part of your house. The main function of the collecting duct is to reabsorb water to concentrate the urine. And this is largely under the direction of both antidiuretic hormone, also known as vasopressin, and aldosterone. Generally, the amount of water, sodium and water that's reabsorbed is a small amount, 4 to 5%. But in severe dehydration, the body can absorb up to 25% of the water in the tubules. This is another view of the collecting duct. Notice all the individual collecting ducts of each nephron fusing together to form a bigger tube that will eventually empty into the minor calyx, the major calyx, and then the renal pelvis, and finally the ureter. The collecting duct is composed of two different types of cells, the principal cells and the intercalated cells. I want to mention these because you will probably hear about them as you learn about different mechanisms of medications and such, just so you understand where they are. The intercalated cells play an important role in acid-base balance. So damage to these cells is another way that you can have renal tubular acidosis, where the principal cells are more involved in sodium and potassium balance via sodium channels and potassium channels. And this is where the aldosterone and the antidiuretic hormone have an influence on the collecting duct. Essentially, aldosterone increases sodium channels and the sodium-potassium ATPase pumps, and this results in increased reabsorption of sodium. So that's reabsorption, so it's going from the urine to the bloodstream, as well as potassium excretion. So potassium from the bloodstream into the urine. This is a close-up look at how antidiuretic hormone affects the principal cells in the collecting duct. Antidiuretic hormone stimulates water reabsorption from the urine back into the bloodstream by stimulating formation of aquaporins or water channels in the principal cell membrane. These channels transport water through the tubular cells back into the blood, preventing diuresis, hence the name antidiuretic hormone. Looking at the chart where the blue arrow is pointing, this is showing a hydrated state where you would have low diuretic hormone in the bloodstream and resulting in less water being absorbed back into the bloodstream. In comparison, if you look next to where the blue star is located, this is what happens when you're dehydrated. Your body secretes more ADH, which then stimulates the production of more aquaporins or water channels, and this results in more water reabsorbed into the bloodstream, hence an antidiuretic effect. The last slide of this section is a summary of secretion and reabsorption in the nephron and can be a good snapshot of what we just learned. Starting with the glomerulus, this is the beginning of filtration, where you have separation of larger cells and proteins from electrolytes and filtering of medications. Next is the proximal convoluted tubule, with primary reabsorption from the urine to blood of water, sodium, and bicarbonate. Next, the descending loop of Henle is primarily reabsorbing water. The ascending loop of Henle is primarily reabsorbing sodium. The distal convoluted tubule is doing the fine-tuning under the direction of aldosterone, involved in the secretion of potassium and hydrogen, and the reabsorbing of sodium and water. And lastly, the collecting duct, which is reabsorbing water under the direction of antidiuretic hormone. Great work, everyone. I appreciate your attention. I would encourage you to take a little break, and then we're going to move on and talk about diuretics. Hi, welcome back. We are now going to make some clinical applications to what we just learned about the nephron in looking at the mechanism of action of diuretics. Diuretic drugs increase urine output, and they do this by altering how the kidney handles either sodium and or water. So let's review where sodium and water are absorbed. We see 65 to 70% of the reabsorbed sodium in the proximal convoluted tubule. The thick descending limb of the loop of Henle plays a big role in water absorption. The thick ascending limb more so in sodium reabsorption, up to 25%. The distal convoluted tubule just does the fine-tuning, about 5% of the sodium reabsorption, and the collecting duct, small amount of sodium, 1 to 2%, and generally small amount of water unless there is more influence by the antidiuretic hormone. Diuretics are generally divided into 5 different categories. The first category we'll discuss is loop diuretics, which, as you can imagine, work at the loop of Henle. Their mechanism of action is inhibition of the sodium-potassium chloride transporter in the ascending limb of the loop of Henle. Examples of loop diuretics include furosemide, bumetanide, torsemide, and ethacrynic acid. These are powerful and can lead to excretion of up to 20 to 25% of the filtered sodium. And if the sodium is excreted, water will follow. Keep in mind that loop diuretics also increase calcium and potassium excretion, so you want to watch for secondary hypocalcemia and hypokalemia. And they might not be the best medication in someone with a history of nephrolithiasis due to the increased urinary calcium excretion. This picture shows what happens with the inhibition of the sodium-potassium chloride cotransporter, which is located on the luminal side of the loop of Henle lumen wall. You can see that the sodium is no longer being transported from the luminal side into the interstitial fluid, and this leads to more sodium remaining in the lumen of the tubule, which pulls more water into the lumen of the tubule and makes more urine. The next class of diuretics are the thiazide diuretics. They work by inhibiting the sodium chloride cotransporter by competing for the chloride site in the distal convoluted tubule. Some examples are chlorothiazide and hydrochlorothiazide. Like the loop diuretics, they also have the side effect of hypokalemia. The mechanism of the hypokalemia is that the increase in the sodium concentration in the distal convoluted tubule stimulates the aldosterone-sensitive sodium pump to increase reabsorption in exchange for potassium and hydrogen ions, which are then lost in the urine, leading to serum hypokalemia. The next class of diuretics are the potassium-sparing diuretics, which act on the principal cells of the distal convoluted tubules as well as on the collecting duct. They overall have a weak natriuretic effect, so they're not real strong as diuretics, but they do help to decrease potassium losses, and so often they're used in conjunction with loop diuretics to prevent hypokalemia. Miloride and triamterene are cations, are two potassium-sparing diuretics, and they block the sodium reabsorption, but they don't affect the mineralocorticoid receptors. Remember, mineralocorticoids are corticosteroid hormones that are synthesized by the adrenal cortex, such as aldosterone. In contrast, spironolactone actually inhibits the aldosterone receptors. Remember that aldosterone increases sodium channels and sodium-potassium ATPase pumps and result in increased sodium reabsorption and potassium excretion. So essentially that process is being blocked, and that's how these are potassium sparing. The next class of diuretics are the osmotic diuretics. These come only in an IV formulation, so they can only be used in a hospital setting. They work by increasing the solute concentration inside the tubules to attract water. They also increase excretion of sodium, potassium, and calcium. Some examples are mannitol, isosorbide, and glycerin. They don't act with the renal transport systems, but work by increasing the osmolarity of blood and the renal filtrate. We actually use mannitol in the operating room when we're doing kidney transplants to increase the urine output without taxing the function of the new kidney. The net diuresis is actually minimal as fluid is delivered out of the proximal tubule, but usually reclaimed back in the loop of Henle. But there are some situations where, like I mentioned during our transplant surgery, where this diuretic is useful. The final class of diuretics are the carbonic anhydrase inhibitors, and they work primarily in the proximal convoluted tubule. They block carbonic anhydrase, as their name suggests, which blunts bicarbonate reabsorption and causes diuresis. Some examples are acetazolamide and dorzolamide. Most medications that end in zolamide are going to be in this class. And generally, they have specific applications and are used in the management and treatment of glaucoma, idiopathic intracranial hypertension, altitude sickness, congestive heart failure, and epilepsy. This is a nice summary slide that shows you visually where on the nephron each diuretic is working. The only one not listed here is the osmotic diuretic, as it is working to increase solute in the tubule and could be anywhere along the nephron. This osmotic diuretic can work. Next, we're going to switch gears and lastly talk about the neuro and hormonal influences that act on the kidney, as well as some substances that the kidney makes and hence need to be considered in patients with renal failure. There are two key hormones that increase arterial resistance and in turn reduce renal blood flow. These are adrenaline or epinephrine and angiotensin II. Adrenaline is excreted by the adrenal gland in response to sympathetic stimulation. This is your fight or flight response. Then epinephrine binds to the alpha-1 adrenergic receptors along the afferent and efferent arterioles, causing vasoconstriction, and hence decreased blood flow into the glomerulus. Angiotensin II is synthesized by the endothelial cells throughout the body in response to low blood pressure as part of the renin-aldosterone-angiotensin cascade. Angiotensin II binds to receptors along the afferent and efferent arterioles, causing vasoconstriction. Angiotensin II also stimulates the release of aldosterone. Angiotensin II is the main effector molecule in the renin-angiotensin-aldosterone cascade. And I pointed it out in this schematic using the blue stars. But I'm going to go through the whole cascade so you can see where the angiotensin II fits in. Starting up in the upper left-hand corner, we have a drop in blood pressure or a drop in fluid volume, which leads to release of renin from the kidney. The renin then converts angiotensinogen to angiotensin I. Next, the angiotensin converting enzyme, or ACE, is released from the lungs and leads to the conversion of angiotensin 1 to angiotensin 2. This then leads to two different effects. The first being direct vasoconstriction of both the afferent and afferent arteriole by angiotensin 2. The second effect is angiotensin 2 on the adrenal gland, which stimulates the release of aldosterone, which then stimulates the kidney to reabsorb sodium, chloride, and water. We touched upon antidiuretic hormone, or ADH, also called vasopressin, in previous discussion of its effect on the distal convoluted tubule and the collecting duct. More specifically, ADH is a hormone produced by the hypothalamus and stored in the posterior pituitary gland. It regulates and balances the amount of water in your blood. It does this by inducing expression of water transport proteins in the late distal tubule and collecting duct to increase water reabsorption. Osmolarity and volume status are the two greatest factors that affect ADH secretion. Looking at the chart, you can follow this process, starting with the brown rectangle at the bottom of the chart, which becomes the stimulus when blood osmolality stimulates osmoreceptors in the hypothalamus to trigger the release of ADH. The ADH then increases the water channels, or the aquaporins, in the collecting duct to increase permeability so that more fluid is reabsorbed into the bloodstream. This water reabsorption then helps to prevent further osmolarity increases and acts as a feedback loop back onto the homeostasis in the bloodstream. So we've talked about a few substances that act on the kidney and adjust its function. Now we're going to talk about a few substances produced by the kidney that are important to know. The first is erythropoietin, which is a glycoprotein produced by the kidney whose receptors are on the red blood cell precursors. Binding of the protein prevents apoptosis of the cells so that they can complete their development and mature into red blood cells. Erythropoietin is produced by the mesangial cells located between the renal cortex and the medulla in the glomerulus. In the picture, you can see the beginning of the red blood cell, which is the hematopoietic stem cell, and how it goes through many different stages to develop into an erythrocyte, and how 3 of those stages are dependent on erythropoietin. Erythropoietin production is stimulated by low oxygen carrying capacity, such as anemia, hypoxia, and low red blood cell flow. The kidney produces 90% of the erythropoietin in the body, and this is an endocrine function. Patients in renal failure will be chronically anemic due to this loss of epogen production. Fortunately, there is an exogenous erythropoietin known as erythropoietin stimulating agent, ESA, and this can be injected or given during hemodialysis for patients in renal failure, and this is known by epogen or Retacrit. Calcitriol, also known as 1,25-dihydroxyvitamin D3, is the active form of vitamin D. As you can see from the picture included on the slide, you can obtain the precursors of 1,25-dihydroxyvitamin D3 from sunlight or dietary intake converted by the liver. But the kidney makes that final conversion from 25-hydroxyvitamin D3 to 1,25-dihydroxyvitamin D3, which is the pivotal step in making it active and useful for calcium balance in the body. This conversion in the kidney is done in the proximal tubule via an 1-alpha hydroxylase. Those with renal dysfunction require a synthetic form of the 1,25-dihydroxyvitamin D3, which is called calcitriol. This comes in pill form and can be taken by patients on a daily basis. How exactly does calcitriol affect the calcium balance in the body? Well, there are 3 different ways. Calcitriol stimulates the small intestine to absorb calcium and phosphates. from what you've ingested in your diet. It also increases calcium reabsorption in the kidney. And lastly, along with parathyroid hormone, regulates bone growth. A lack of calcitriol production leads to low serum calcium levels and eventually secondary hyperparathyroidism, which we'll talk about in the next slide. Secondary hyperparathyroidism is a condition in which a disease outside of the parathyroid glands causes the glands to become enlarged and hyperactive. An example of a condition within the parathyroid glands that would cause the same findings would be, say, a parathyroid adenoma. But the secondary hyperparathyroidism is due to the renal failure. And the way renal failure leads to this condition is through two different mechanisms. First, the kidney is secreting less phosphorus, which leads to increased serum phosphorus levels. This phosphorus then binds to the free calcium, decreasing the serum calcium levels, which then stimulates the parathyroid glands to secrete more parathyroid hormone and pulls calcium from the bones to the serum. Secondly, the kidneys are making less calcitriol, which decreases calcium absorption in the gut, leading to increased parathyroid hormone production. A patient with secondary hyperparathyroidism would have lab findings including low serum calcium, high serum phosphorus, and high parathyroid hormone secretion. The treatment of secondary hyperparathyroidism consists of either decreasing phosphorus or increasing calcium in the bloodstream, and this can be accomplished in different ways. A patient can follow a low phosphorus diet or take phosphate binders. These are taken with meals and it binds the phosphorus in their meal. A common phosphate binder is Foslo, which is calcium acetate. They can also take vitamin D derivatives such as calcitriol or calcimimetics. A calcimimetic is a medication that binds the calcium-sensing receptors, making it more sensitive to serum calcium and results in a reduction of serum PTH at lower levels of serum calcium. So essentially, it mimics the action of calcium on the tissues. And I have a picture of that in the next slide. An example of a calcimimetic is Sensipar, which is a pill that can be taken daily. Here you can see a schematic of the calcimimetic's effect on parathyroid hormone synthesis as the molecule binds in the usual calcium receptor on the parathyroid gland, lending to decreased PTH synthesis. So essentially mimicking the action of calcium on the tissues. All right, everyone, you did it. Thank you for your attention and diligence to this slides and lecture. There will be some case studies that will give you the opportunity to practice some of these concepts. Thank you.